Welcome to the VascuLens Vascular Access Lab. This expanded simulation demonstrates ultrasound-guided placement of a long peripheral IV, including image optimization, short-axis needle tip control, flashback, catheter advancement, long-axis confirmation, connection, and flushing. It is education for trained clinicians, not a substitute for local policy, manufacturer instructions, supervised competency, or patient-specific judgment. Begin with the patient and the plan. Verify identity, indication, allergies, prescribed therapy, and whether a peripheral IV is the appropriate device. Explain the procedure, position the arm comfortably, perform hand hygiene, and assemble the equipment. In this simulation, the upper arm and biceps are screen left, and the wrist is screen right. The catheter will therefore advance from right to left, distal to proximal, toward the biceps. The simulated device is a pink 20-gauge, 2.5-inch long peripheral angiocatheter. Its appearance is modeled on a clear hub, safety-style catheter over needle assembly, but it is not an exact commercial product. Use a high-frequency linear array transducer. The realistic probe on the arm and the beam diagram now move from the same coordinates as the ultrasound image. 4 deliberate manipulations optimize the view. Sliding translates the footprint across the skin. Rocking, sometimes called heel-toe, changes the angle along the probe's long axis while maintaining contact. Fanning or tilting sweeps the beam through tissue without translating the footprint. Pressure compresses superficial structures. Keep the orientation marker consistent with the screen marker. First, slide slowly across the extremity and short axis. On the B-mode display, structures move in the opposite direction of the probe. Survey proximally and distally rather than accepting the first vessel. A suitable vein is thin-walled, non-pulsatile, and completely compressible. An artery is usually rounder, more pulsatile, and resists complete compression. Identify nerves and other hazards, then trace the target vein to avoid valves, bifurcations, and an unsuitable catheter path. Center the vessel, then optimize depth so the target occupies the middle portion of the screen. Adjust gain until the lumen is dark, but the vessel wall and surrounding tissue remain visible. Place the focal zone at the vessel depth. Rock the probe to make the beam more perpendicular. The wall becomes sharper and the target more symmetric. Fan through the vessel to find its widest diameter. Notice that rocking changes brightness and shape, while fanning makes the target enter and leave the imaging plane. Now compare compression. Apply gentle, graded pressure directly over the centered vessels. The vein flattens and should collapse completely. The artery remains patent and may continue to pulsate. Release pressure and confirm that the vein returns to its original shape. Excess pressure can hide the target and can also prevent venous filling, so use only enough force to answer the question. If the vessel does not compress as expected, stop and reassess rather than assuming it is a usable vein. Measure depth and diameter, then select a catheter gauge and length appropriate for the therapy, vessel, manufacturer instructions, and local policy. Prepare the transducer and gel using the required barrier precautions. Clean the skin with the approved antiseptic and allow it to dry completely. Do not repalpate the prepared site unless a septic technique is maintained. Reconfirm that the planned path is directed proximally, away from the wrist and toward the biceps. For short axis guidance, hold the probe steady over the vessel and insert the catheter immediately distal to the probe at a shallow angle, aiming right to left. The B-mode image shows the leading tip as a bright dot. A bright dot may also be shaft, so stop whenever the true tip is uncertain. Use dynamic needle tip positioning. Slide the probe a few millimeters proximally until the tip disappears. Hold the needle motionless, then creep the needle forward until the leading tip reappears in the beam. Repeat probe first, needle second. The surface, subdermal, beam, and B-mode views are all synchronized to that same sequence. As the tip approaches the anterior wall, reduce the size of every movement. Watch for tenting, then confirm that the leading tip enters and centers within the lumen. Blood now appears first along the notched needle region and then in the transparent flashback chamber. Flashback supports vessel entry, but it does not prove that enough catheter is safely inside. Lower the insertion angle and advance the needle catheter assembly a short distance while keeping the tip centered and protecting the posterior wall. Stabilize the needle and advance only the flexible catheter from right to left into the vein. The pink hub moves toward the skin while the transparent catheter progresses proximally within the lumen. Never force the catheter and never advance the needle again after the catheter has been threaded. Release the tourniquet, apply venous control as permitted by the device and policy, activate the safety mechanism, and discard the sharp immediately. Before connection, rotate the linear probe 90 degrees to obtain a long axis or longitudinal confirmation view. Keep the vessel centered during the rotation so it does not disappear. In long axis, the vein becomes a tubular structure and the catheter should be visible as a linear echogenic structure traveling within the lumen. Slide and fan gently to follow it. Confirm that the catheter is intraluminal and that the tip has not crossed the posterior wall. Long-axis confirmation complements, not replaces, continuous tip control during insertion. Connect a primed extension set and needleless saline lock connector using aseptic technique. Stabilize the hub so the catheter is not pulled back. Flush according to local policy while observing the patient and the site. On the arm view, the syringe plunger advances through the connected saline lock. On ultrasound, a brief stream of intraluminal echoes and mixing moves proximally through the vein. There should be no pain, resistance, leaking, swelling, or extravascular fluid collection. Stop immediately if infiltration, arterial placement, nerve symptoms, or another complication is suspected. Secure the catheter with the approved sterile dressing and stabilization method, label it as required, and document the site, gauge length, number of attempts, ultrasound guidance, patency assessment, and patient response. In Vasculens, success means that the proximal direction was correct, the vein was differentiated by compression, the leading tip stayed controlled, flashback was interpreted in context, the catheter was seated and confirmed in the lumen, and the flush remained intravascular. Reset and repeat until those steps are consistent, then validate the complete skill with an expert preceptor before clinical use.